My topic today is updates on management strategies in pheochromocytoma. Presentation will include introduction, clinical presentation, investigations, diagnosis, treatment, and special forms of pheochromocytoma. Pheochromocytoma is a neuroendocrine tumor of the adrenal medulla of the adrenal gland that secretes excessive amounts of catecholamines, which are very powerful vasoactive hormones. The estimated annual incidence is 2 to 8 per million person. The average age at diagnosis is 25 years in hereditary cases and 44 years in sporadic ones. Men and women are equally affected. Pheochromocytoma is called the 10% tumor due to the classic association of being 10% familial, bilateral, malignant, extraadrenal, and in children. However, this has not become true anymore, as up to 40% of the cases are attributed to genetic alterations. Moreover, hereditary syndromes have higher proportion of bilateral pheochromocytomas compared to sporadic occurrences. And also, malignant potential depends on the underlying mutation, and various reports estimated rates of malignancy up to 26%. Based on biochemical secretory patterns, pheochromocytomas can be characterized into 3 different phenotypes. Noradrenergic phenotype, predominantly producing norepinephrine, adrenergic phenotype, predominantly producing epinephrine, and a third rare biochemical phenotype, mainly producing dopamine. Around 68% of cases of pheochromocytoma occur sporadically, 13% associated with von Hippel-Lindau syndrome, about 6% associated with succinate dehydrogenase subunit B, 5% associated with multiple endocrine neoplasia type 2, 4% associated with neurofibromatosis type 1, and another 4% associated with succinate dehydrogenase subunit D gene mutation. Several susceptibility genes have been found to play a central role in the etiology of pheochromocytoma, and a cluster of different genes have been implicated in the pathogenesis. Cluster 1, associated with abnormal hypoxia-inducible factor activation and overexpression of androgenic factors. It includes mutations of von Hippel-Lindau tumor suppressor gene, succinate dehydrogenase subunits B and D gene mutations. Cluster 2 is associated with abnormal activation of kinase signaling pathways, leading to abnormal cell growth and lack of apoptosis. It includes mutations in the red proto-oncogene associated with multiple endocrine neoplasia and the neurofibromatosis type 1 tumor suppressor gene. Clinical presentation of pheochromocytoma varies considerably from being asymptomatic up to catastrophic disease. The classical clinical picture is that of episodic hypertension, palpitation, sweating, headache, and anxiety. Can pheochromocytoma cause hypotension? Actually, hypotension occurs in many patients with pheochromocytoma. This is due to intense alpha-adrenergic-mediated vasoconstriction with volume contraction, or beta-adrenergic-mediated vasodilation, or maybe due to tumor release of adrenomedullin. Lab diagnosis of pheochromocytoma includes 24-hour urinary free metanephrines and catecholamines, plasma metanephrines and catecholamines, dynamic endocrine testing, and serum chromogranin A. Tumor localization by imaging modalities includes CT, MRI, MIBG scan, PET scan, and recent techniques using CT, PET, and MRI, MIBG scan. 24-hour urinary free metanephrines are superior to urinary catecholamines and plasma catecholamines and are considered the best biochemical diagnostic test for pheochromocytoma. However, false positive results can occur with drugs as beta blockers, amphetamines, sympathomimetics, also with major physical stresses, hypoglycemia, stroke, and obstructive sleep apnea. In fact, obstructive sleep apnea is associated with marked elevation of catecholamines and sympathetic overactivity in the setting of uncontrolled obstructive sleep apnea. False negative results can occur due to oxidative degradation in the lab, or sampling may be incomplete, or in small tumors. Plasma catecholamines should be drawn while patient supine with catheter in place for more than 30 minutes. Plasma metanephrines are not postural dependent and are preferable in patients with renal insufficiency and in children. False positive can occur with acetaminophen. Dynamic testing is clonidine suppression test. Patients will have unsuppressed plasma norepinephrine, may precipitate hypotensive shock. Glucagon stimulation test. Patients will have more than threefold increase in plasma norepinephrine, may precipitate hypertensive crisis. However, these tests are not preferred for the diagnosis of pheochromocytoma. Serum chromogranin A is a well-known marker for neuroendocrine tumors. It is a storage vesicle protein that is co-stored and co-secreted with catecholamines. It's elevated in up to 89% of cases of pheochromocytomas. Serum chromogranin A in association with urine metanephrines improves sensitivity of diagnostic and long-term follow-up testing and can detect recurrent pheochromocytomas. Imaging techniques for tumor localization. CT is the gold standard for localizing adrenal pheochromocytoma with sensitivity up to 100%. And most pheochromocytomas show enhancement more than 10,000 field units with avid contrast enhancement delayed washout due to capillary network in the tumor. MRI is more sensitive for extra-adrenal tumors. Scintigraphic studies can be complementary in those instances in which the anatomical imaging study is equivocal or in cases for diagnosis of metastasis. Using radiolabeled meta-iodobenzyl guanidine scintigraphy, octreotide scan, and the success of this modality depends upon the somatostatin receptors found in the tumor, and PET scan. Sensitivity of MIBG scan for detection of pheochromocytoma reaches up to 90%. It determines metastasis, paragangliomas, and evaluates for tumor recurrence. This is an example of MIBG scan showing right-sided pheochromocytoma, and this is another example showing diffuse metastatic pheochromocytoma. False positive MIBG uptake can occur with hyperplasia after unilateral adrenectomy, can be confused with normal physiological uptake or other neuroendocrine tumors. False negative results can occur if small-sized tumor, necrosis in the tumor, or drugs as labetalol or phenothiazines. Recent modalities, CT, PET, and MIBG scan can be used for precise detection and localization of tumors. In addition, functional state assessment, detection of paragangliomas, metastasis, evaluate for recurrence. For example, differentiate between scar tissue versus recurrent tumor, and for evaluation of the therapeutic intervention efficacy. There is often diagnostic delay in cases of pheochromocytoma, and therefore early consideration of the tumor is important. Whenever there is a suggestive clinical picture, diagnosis is confirmed by the demonstration of urinary metanephrines in 24-hour urine samples and the tumor localization using CT scan. There are certain situations that can mimic pheochromocytoma and should be put in the differential diagnosis, as carcinoid tumor, menopausal symptoms, hyperthyroidism, hypoglycemia, migraine, and panic disorders. Who should be screened for pheochromocytoma? Patients with multiple endocrine neoplasia type 2A and 2B, patients with von Hippel-Lindau syndrome, patients with neurofibromatosis type 1, first-degree relatives of these diseases, patients with resistant hypertension, and patients developing hypertensive crisis during surgery or general anesthesia. Genetic testing should be done for patients with bilateral, recurrent, or multifocal pheochromocytoma, patients with paraganglioma, and patients with family history of paraganglioma or pheochromocytoma. However, a consensus statement for the diagnostic testing of hereditary pheochromocytoma in 2017 stated that pheochromocytoma and the paragangliomas are one of the highly heritable tumors in humans, and that genetic testing has been recommended in all patients with pheochromocytoma and paraganglioma independent of a clear family history. Treatment options include surgery, medical treatment, radiation therapy, and gene-directed therapy. Surgical excision of pheochromocytoma is the definitive treatment. Prior to 1951, reported mortality for excision of pheochromocytoma reached up to 50% due to hypertensive crisis, arrhythmia, stroke. Yet, currently, mortality is about 2 to 4% due to minimally invasive approaches and better perioperative management. Preoperatively, patients receive selective alpha blocker or both alpha and beta blockade, and if blood pressure is still uncontrolled, we can add calcium channel blocker. Intraoperatively, IV phentolamine, IV nitroprusside or short-acting beta blocker. Post-operatively, about 75% of the patients are normotensive, and the remaining 25% have easily be controllable blood pressure. 24-hour urine collection should be done 2 weeks post-operatively to check for the success of the surgery, because urine catecholamines are expected to return to normal in 1 week after surgery. Medical therapy includes alpha blockers, beta blockers, vasodilators, and calcium channel blockers. Hypertensive crisis is controlled with IV phentolamine, nitroprusside, esmolol, or labetalol. Radionucleotide treatment can be considered in patients with metastatic, surgically incurable, or recurrent pheochromocytomas using radiolabeled MIBG, better responses in patients with limited diseases and soft tissue metastasis. Radiolabeled somatostatin analog, effective in reducing hormone secretion and determined tumor shrinkage. External radiation therapy for distant metastasis, especially bone metastasis. Gene and molecular target therapy are new promising strategies in the treatment of pheochromocytoma. By the interference with the specific molecular targets along the oncogenic signaling pathways responsible for both benign and malignant pheochromocytoma gene mutations, example hypoxia-inducible factor inhibitors, vascular endothelial growth factors, mTOR inhibitors in combination with octreotide. Prognosis. About 74% of the patients are hypertensive-free for 5 years and 45% of the patients for 10 years. Tumor recurrence rates averages around 10%. The presence of succinate dehydrogenase B mutation and a tumor size more than 6 cm are the most important predictors of recurrence. The European Society of Endocrinology Clinical Practice Guidelines 2016 recommended follow-up for at least 10 years in all patients, and those with high risk who are young and those with genetic disease, large tumor or paraganglioma should be offered lifelong annual follow-up. Special forms of pheochromocytoma include malignant pheochromocytoma. WHO defines malignant pheochromocytomas by the presence of metastases at sites where chromaffin tissue is not normally present. Malignant potential is found to be higher in patients with pheochromocytomas more than 5 cm in size, paragangliomas, and familial cases. Treatment using combination of chemotherapy, irradiation, everolimus or sunitinib, and radiotherapy for metastasis. Pheochromocytoma and pregnancy. Pheochromocytoma is a rare condition during pregnancy. The main clinical manifestation is hypertension, headache, and palpitation can be also presenting features. Usual time of presentation is at labor or postpartum, and therefore should be differentiated from eclampsia. Diagnosed with 24-hour urinary epinephrine and MRI. Don't do CT or MIBG scan during pregnancy. First trimester treatment can be used with medical treatment using drugs that are relatively safe during pregnancy. Second trimester, using surgical resection of the tumor can be done. In the third trimester, delivery is planned with concurrent or delayed adrenalectomy. Asymptomatic pheochromocytoma. Pheochromocytoma are increasingly being diagnosed during the workup of adrenal isthentalomas detected by abdominal imaging performed for other reasons. Asymptomatic adrenal mass was the initial presentation in up to 25% of the cases in the recent series in the United States. About 50% of pheochromocytomas are diagnosed only at autopsy because many of these tumors remain clinically silent during life. Take-home message. Pheochromocytoma should be considered in every patient with paroxysms of hypertension, headache, and palpitation, patients with family history, and patients with genetic syndromes. First, do biochemical testing the tumor localization by imaging. Check interfering medication before testing. Only modality is curative treatment by surgery. Proper perioperative management improves surgical outcome. Gene mutations are reported in up to 79% of cases, making genetic screening mandatory. Gene-directed therapy is hopefully a promising novel strategy for the treatment of pheochromocytoma. Thank you.